The three-phase model of care for treatment of individuals who have experienced trauma, that is, the phase one is safety and symptom stabilization. So safety, we do know how different ways in which we can ensure, and again we'll demonstrate in another role play. Other than that, we develop rapport by empathic reflection. Yes, that must be suffocating. That sounds very hard. That sounds isolating. That must be really difficult to go through that, and at such a young age. You must have really felt uh, lonely then. You must have this sounds like it would be very scary. So when you do that, when you use non-judgmental attitude, no, you're not a bad person for feeling this way. No, you're not a bad person that you became hypersexual after your sexual abuse. This is a common reaction that does happen. When you normalize these this trauma impact, then a rapport gets developed, and the person starts to feel safe in with you. And along with that, what do we mean by symptom stabilization? Like for example, this patient, the first patient we talked about had OCD, right? The second patient we talked about also had some intrusive images. So we take care of that before we begin trauma treatment. Or some people may be having panic attacks, some may be having non-suicidal self-injury or self-harm. So we take care of those aspects first. Or maybe there is a person whose routine is haywire, who's not eating well, who's not sleeping well. Then we first take care of those things, and then we move on to the second phase. So after a person is stable, we move to the second phase, which is the processing of traumatic memories. We make sure before we move here that the patient has developed good coping strategies. And those we have started to use anyway, right? From the very first session, we are doing deep breathing with them. We are teaching them grounding techniques. We are teaching them relaxation techniques of different kinds. And then whatever they feel they are better adjusted to, we are asking them to repeat as homework assignments. When they feel that yes, I'm able to get a good grip on myself, like I'll share examples of actual patients. Like one of my patients once recently, who was self harming a lot, said that, I had a really bad urge to self harm, but then, like you always say, I was able to surf the wave of the urge, and I did not end up self harming. So that showed me that patient is now ready to process the traumatic memories, because they were able to demonstrate good coping skills. Or another person who said, I have not self harmed for 3 months now, I have not abused any drugs for a couple of months now, I'm studying, and I think I'll score really well in my exams. That means they are ready to now move to the phase 2, right? When they are stable in their life, in all other aspects of life. Because first we need a solid ground to explore trauma. First we need to create that foundation with the phase 1. So in phase 2, we see all of those things, and then we can ask the client where they want to begin, ask open ended questions about their trauma, help them verbalize whatever they are seeing, experiencing, however they want to if they want to verbalize the trauma narrative, if they want to draw it out to us, if they want to write a letter and bring it and read it aloud, how if they want to make a video on it and show us, whatever their way of narrating the trauma is. And even while doing that, we do something called pendulation, where, so this grounding exercise that I did in the last, this is something that can be done throughout the session, where the technique which is called pendulation, where we ask the person to oscillate between the two. Okay, now let's do grounding. Now again, let's come back to the trauma narration, because trauma narration is taking one to the past, whereas grounding is bringing one back to the present. And yes, I do remember we will talk about the biological mechanism behind it as well shortly. So hang in there with that question, right? So we use grounding techniques, we can use deep breathing also, and we pace the trauma processing or pendulate that way, so we don't go fast there as well. So this is a very important part, of course, of trauma treatment. This is the main part. But after this is done, still lot of things are left. Now our patient may never have learned some certain skills. So for example, a patient, I'm real case I'm sharing, who was abused at age 11. uh, do you think she could have ever developed the skill to trust other people or be in trustworthy interpersonal relationships? It's not possible, right? She was abused in when she was 11, and then again briefly in another other two incidents. So we have to then build those skills on how to have good interpersonal skills, how to be assertive, how to have a sense of boundaries. Maybe sexuality education could be needed for a person who had an sexual encounter early on in their life and could not learn about sexuality in a healthy way, always had a negative connotation attached to it. So we have to now get them to re-engage with others and with life, with self in a healthy manner. We also have to build on the whatever learning has happened. So that is what we do in the last phase. These are the three phases of now. Talking about trauma focused therapies, there are multiple therapies, and they are uh, mainly into two approaches we can put them. One is what we call the top down approaches, where we help clients to think differently, like CBT, DBT, etc. And the other are what we call bottom up approaches, where we help them deal with raw emotions and defense reactions like EMDR, yoga, dance and movement therapy, etc. Research has found that bottom up approaches alone or in combination with top down approaches are way more successful. So we talked about bottom up and top down approaches, right? I'll give you a very practical example of this. How many of you have seen that movie Three Idiots? Right, in that Amir Khan says this, all is well, right? Now we want to be able to tell our brain, when we are anxious, this part of our brain lights up and it says there is danger. It makes us in go in survival mode. Right now, when we are in survival mode, we want this part of the brain to calm down. We want to communicate to it that all is well and you can calm down. Approaches use this part, the prefrontal cortex, where logic resides, when we are actively saying it all is well, we are using our logic to say that no need to get worried, it's going to be okay, all is well. But that doesn't reach the first stair, right? We have to reach the first stair, but top down approaches are using the third stair. So what works is using these bottom up approaches, where when you're grounding yourself, you're saying, see, I am grounded here in this situation, in this room. My grounding is not in, I'm not in the traumatic situation itself. So then it's easier for you, then it's possible for your brain to remember, to come out of the survival mode and go, okay, then really all is well, if you're grounding yourself this way. When I'm slow breathing, I'm communicating through my body, through the vagus nerves in my body to my brain, that I would not have been slow breathing if all was not well. I would have been hyperventilating. So because I'm slow breathing, all is really well, right? So this is when we do grounding or slow breathing, it's our body communicating to our brain that all is well, and that's why it works. And that's what is called a bottom up approach, where we work on the seat where raw emotions happen, which is the first stair of our brain.